Okay. So the last week when we met, we look at the digestive system, gross anatomy of the digestive system. I expect the physiology lecturer to continue the rest. So we look at the main function of the digestive system to break down food into simple units that the body can absorb. And of course, the undigested food will be eliminated. So we look at the two main divisions, the gastrointestinal tract and the accessory digestive organs. We did an overview of the abdomen division into four quadrants and to nine abdominal regions. We look at the digestive processes, ingestion, propulsion, digestion, absorption, and ejection. We explain the propulsion, swallowing, peristalsis, mass movement. Then in terms of digestion, mechanical digestion, we explain the channel that occurs in the stomach and segmentation as occurs in the small intestines. We started with the oral cavity, where we look at the oral cavity, the two regions of the oral cavity, the vestibule and the oral cavity proper. We look at the boundaries of the oral cavity. We said that posteriorly it opens into the oropharynx through the fauces. And where the fauces, we can see the palatine tonsil. The palate separating the oral cavity from the nasal cavity. We look at, we talk about the function of the uvula, the function of the lingual frenulum. We look at the tongue, the intrinsic and extrinsic muscle of the tongue. So this one was talking about the lingual frenulum. The dorsum of the tongue divided into anterior two-third and posterior one-third. The anterior two-third having elevations that we call papillae. We identified all the papillae, the filiform, the folate, the valate, and the filiform. The filiform is not shown here. Okay, it's shown here. Filiform, fungiform, folate, circumvallate, or valate. We said that they all contain taste buds, except, of course, the filiform papillae. We looked at the extrinsic muscles of the tongue, the styloglossus, palatoglossus, hyoglossus, and the genioglossus. We look at their innervation, that they are all innervated by the cranial nerve 12, except, of course, the palatoglossus. We explain the role of the tongue in digestive process. We also look at the salivary glands, the perisalivary glands, the parotid, the submandibular, the sublingual. We look at the composition of the saliva and the one that contributes most to the saliva, which we said is the submandibular gland. And we look at how they open into the oral cavity. The parotid has a single dart, open opposite the second upper molar teeth. The submandibular also has a single dart, but the sublingual has several darts, and they all open on the other side of the lingual frenulum. This is the opening of the parotid dart. And we look at the role of the component of the saliva and how they help in the digestive process. We also look at the teeth, deciduous permanent teeth. We look at the structure, the different types of teeth. We look at the structure of a typical teeth, here being the mandibular molar. We talk about the crown, the bulk of the teeth being made up of the dentine, the crown being protected by the enamel, the root being protected by the cementum. We mentioned the periodontal ligament. I even mentioned the ameloblasts that produce the enamel, and the fact that when the teeth erupt, it degenerates. And that is the reason when there's a crack in the enamel, it has to be filled with artificial substance. We also look at the serous membrane lining, the pelvic cavity, the visceral peritoneum, the parietal peritoneum. We look at the space between the two, being the peritoneal cavity, and the fact that it's closed in males, it's open in females. We talk about peritonitis, which is inflammation of the peritoneum, which is a life-threatening condition. We divided the peritoneal cavity into two, the greater sac and the lesser sac being behind the stomach and the lesser omentum. We look at the peritoneal organs, we group them into intraperitoneal organs and retroperitoneal organs. The kidney being retroperitoneal, the pancreas, the ascending, the descending colon, the duodenum, and the upper and middle rectum being retroperitoneal organs. Retro means behind the peritoneum. Although when I was teaching you, I didn't talk about it, but then we have the retroperitoneal can be grouped into two, the primary retroperitoneal organs and the secondary retroperitoneal organs. The primary retroperitoneal organs, basically, retroperitoneal means they are behind the peritoneum. So you can see the kidney behind the peritoneum, the duodenum, most part of it being behind the peritoneum, the pancreas being behind the peritoneum. We have the primary and secondary retroperitoneal organs. What it means is that in primary retroperitoneal organs, throughout development, they were behind the peritoneum. So a typical example would be the kidneys and the adrenal glands. They are primary retroperitoneal organs. Then the secondary retroperitoneal organs, they initially they were intraperitoneal, but then they were intraperitoneal, but then became retroperitoneal. The reason being that intraperitoneal organs are suspended within the peritoneal cavity by the mesentery. So in secondary retroperitoneal organs, they had the mesentery initially, but they lost it. So the pancreas, the ascending descending colon are typical examples of secondary retroperitoneal organs. Primary one, you can't forget the kidney. They never had a mesentery during development, so they've always remained behind the peritoneum. Then we also talk about the structures that the peritoneum forms. We said that it forms ligaments, it forms the omentum, it forms the mesentery, and it creates spaces where fluid can even accumulate. So we said that there is a lesser omentum connecting the stomach, the lesser cavity of the stomach, the first part of the duodenum to the liver, the greater omentum. And there's a transverse mesocolon, the sigmoid-mesocolon. Then there's a mesentery proper. We describe the greater omentum as the abdominal policeman. Then we also look at the paracolic gallets, which are basically the spaces on the other side of the ascending and descending colon. So if the ascending colon is here, on the side here is the right paracolic gutter, then we have the left paracolic gutter. And I tried to use this one to explain how infection can spread within the peritoneal cavity. There was a very important space that I mentioned, the space behind the right lobe of the liver, the right subhepatic space. That space also, the space between the liver and the right kidney, the hepatorenal pouch, also called the pouch of Morrison. And I explained that when there's too much, there's fluid in the peritoneal cavity, maybe there's infection. If the person is placed in the supine position, the fluid will accumulate in the pouch of Morrison. And then when the patient is sitting down or upright, then the fluid will collect in the pelvic cavity. And in the pelvic cavity, we have the space between the men, the bladder and the bladder and the rectum, and the females between the uterus and the rectum, which we call the pouch of Douglas. So we look at how someone's abdomen, if it's enlarged, the enlargement, the four F's, either there's fetus, there's gas flatus, or there is a fluid in this case, or ascites, or maybe there's fecal matter. We look at the peritoneum as a very having absorptive function, and hence it's used in peritoneal dialysis. We also said that it can be used in ventricular peritoneal shunt, where excess CSF in the ventricles can drain into the peritoneal cavity. Then we look at how, if there is fluid in the peritoneal cavity, how the fluid can safely be removed in a process that we call parasynthesis. Now, then finally, not finally, we said that from the esophagus to the inner canal, the wall of the GI tract is arranged in concentric ring. Four concentric rings: the mucosa, submucosa, the muscularis externa, and the serosa. So, once we look at the specific part, we'll be looking at the regional differences between these four concentric rings. Basically, the mucosa is made up of epithelium, underlying connective tissue we call the lamina propria, and a muscle layer that we call muscularis mucosa. So this is it. And we said that this muscularis mucosa, when it contracts, helps to in gut secretion. Yes. The next phase is submucosa, the muscularis externa. It is this muscle layer that we said that is responsible for peristalsis sedimentation. So what it means is that the contraction of the muscularis mucosa can be independent of this muscularis externa. The last layer being the serosa. If it's intraperitoneal, then of course is to have the last layer being the serosa. Then I also mentioned two important points that in the submucosa, you may have glands, and it's only in the esophagus, part of the esophagus and the duodenum that you have submucosa glands. Then in terms of the innervation, I said that there's intrinsic innervation of the GI wall. Within the submucosa, there is a nerve plexus, the submucosa nerve plexus, that is responsible for gut secretion. Then between the inner circular and outer longitudinal muscles, you have the myenteric plexus that is responsible for gut motility. So we started with the esophagus being a muscular tube. We look at the upper esophageal sphincter, which is a skeleton at the junction between the pharynx and the esophagus, and the lower esophageal sphincter, that is between the stomach and the esophagus. We look at the three constriction sites, and we said that that is where foreign bodies are likely to lodge. And we also talk about its importance during what instrumentation. But now at least I think we even talk about the mechanism of swallowing, which is a work of physiology. Then we said that the esophagus begins at the lower border of C6, the cricoid cartilage at the vertebral level C6. It pierces the diaphragm at T10, then joins the stomach at T11. In terms of the histology, I explained that the esophagus has a stratified squamous non-keratinized epithelium. Within the lamina, the lower part of the esophagus, in the lamina propria, there are glands, the esophageal cardiac glands, and those ones neutralize the acidic reflux from the stomach. Acidic reflux from the stomach. Then I went further to explain that if this reflux is not the acidic reflux, then it definitely will cause damage. So what happened is that the epithelial lining the lower part of the esophagus will change. Will change to columnar epithelium. And this is what we refer to as metaplasia, where a mature epithelium change to another type of epithelium as a result of chronic irritation. Is an adaptive response. So we call that condition Barrett esophagus. Then I also explained that the esophagus, the upper one third is skeletal, the middle one third is mixed. That's a skeletal and smooth, and the lower one third is just smooth muscle. In fact, we also look at the stomach. We said that the stomach has 4 parts: the cardiac, the fundus, the body, the pyloric parts. There are 2 surfaces, the anterior and posterior surface. There's a lesser curvature and there's a greater curvature of the stomach. There is a cardiac notch and there's also the angular notch. The anterior relations of the stomach, we mentioned the liver and the gallbladder. The posterior relations of the stomach, you can see the pancreas, the left kidney, the spleen, the left adrenal gland. So we explained that posterior ulceration of the stomach will affect the pancreas, and of course the blood vessels over there. The fluid can pass through the epiploic foramen and into the pouch of Morrison at the greater sac. We said that when food is in the stomach, the food will be converted to, the stomach has this very thick layer of muscles. Whereas in the GI, from the esophagus all the way to the neck canal, we talk about the inner circular and outer longitudinal. And we said that in the stomach, there's an inner layer which is oblique. So these muscles, massive muscles in the stomach, is what is responsible for churning of food. And the food is converted to a semi-paste. We also identify the longitudinal folds, the rugae, within the stomach. We have said that these are temporal folds. They help to, as you eat, they stretch to, they stretch. So they are just temporal folds. They don't really increase the surface area for absorption. Then, in the entrance of the esophagus, the stomach to the duodenum, there's a pyloric sphincter which regulates the food into the duodenum. And there, sometimes in congenital pyloric stenosis, the pyloric orifice will be narrow because of the thickening of the pyloric sphincter, and the clinical symptoms of this is projectile vomiting. We also identify some, the epithelium there being simple or columnar epithelium. We also look at the cells, the parietal cells that secrete ACE and intrinsic factor. We explain the importance of this intrinsic factor combined with vitamin B12. So vitamin B12 is absorbed in the small intestine, specifically the ileum. So when there is autoimmune destruction of the parietal cells, that means no intrinsic factors produced. So there's going to be vitamin B12 deficiency, and the person will have pernicious anemia. The chief cell secretes pepsinogen. Is the ACL produced by parietal cells will activate the pepsinogen. In other words, converting it to an active form that we call pepsin. The enteroendocrine cell, like one called the G cells, release gastrin. It is when this gastrin is released that the parietal cells will secrete ACL. Within the wall of the stomach, there are the epithelial cells. There are some mucus-secreting cells there. Yes, there are mucus-secreting cells that lines the stomach to prevent it from auto-digestion. Then we also talk briefly about about ulcers. Number one cause being from this bacteria H. pylori. We also talk about term use of buprenorphine aspirin, and also talk about excessive stomach acid are the three major causes of gastric ulcers. Then we also talk about, is it well, did I stop here or what? Hello? Did we look at the small intestines? And I'm not listening.
Then we did the large intestines.
We even did a lot intestines. Oh, okay, then that's nice. So the small intestines, we said that it extends from the parts of the stomach to the ileocecal junction. It's a primary site for digestion absorption of nutrients. We divided it into three parts.
You didn't do this.
Yo. So I'm doing it. Why? Hey. So the small intestines is the primary site of digestion and absorption of nutrients. It begins from the pyloric part of the stomach to the ileocecal junction, and we are saying that's about 6 meters in adults. The small intestines is divided into three parts. There's a duodenum, there's a jejunum, and there is the ileum. The jejunum is 25 centimeters long. The jejunum and the ileum, normally there is no anatomical distinction point where the jejunum, we can see that this is where the jejunum has ended. So we normally can call it the jejunal ileum. But then the ileum is longer than the jejunum. What I want you to note here is this. And those are the points that I've written here. The jejunum and the ileum are intraperitoneal. The duodenum, the first 2 centimeters is intraperitoneal. The rest are all retroperitoneal. And it is the duodenum that the bowel, there is a duodenum that receive bowel and pancreatic juice. Now, the jejunum is the primary site of nutrient absorption. So that point is very important. Now, this is the duodenum, which is C-shape. C-shape. In fact, anatomically, we divide into 4 parts. The first part is this, which is the superior part. Okay, let me use this one because they color the parts. So this is the first part, the superior part. This is the second part, the descending part. This is the third part, the horizontal part. And this is the fourth part, the ascending part. As I explained, the whole thing is 25 centimeters long. The first part is 2 inches. An inch is about 2.5 centimeters. What you need to note is that, as I said earlier, the first part is 5 centimeters. So the first 2 centimeters is intraperitoneal. All the rest are retroperitoneal. Now, what is important about the first part is that is a site of what they call a duodenal ulcer. It's a site of the duodenal ulcer. You realize that the area is smooth. There are no circular folds as you find the rest of the duodenum. Okay. Now the second part, there's what we call the major duodenal papillae. I'll say that one again later. the major duodenal papillae. The most important thing about the second part is that is where the bile and pancreatic juice enter the duodenum at the major duodenal papillae. Now, the third part, the important point there is the fact that these vessels, the superior mesenteric vessel, they cross the ureter. So here, if you look at it, they cross the duodenum. So if you look at this part here, this is abdominal aorta, this is the IVC, and this is the superior mesenteric vein, the superior mesenteric artery. You can see it crossing the third part of the duodenum. So you see that the duodenum, therefore, is sandwiched between the superior mesenteric vessels and the abdominal aorta. And when the duodenum, the third part of the duodenum is compressed that way, it leads to a phonation. It can lead to obstruction. We refer to that condition as superior mesenteric syndrome. Now, why did I say that the jejunum is the primary site of nutrient absorption? So if you look at here, I'm not even talking about that part. So that's all about the jejunum. Is the first part, apart from the first 2 centimeters, which is intraperitoneal, the rest are all retroperitoneal. The first part is where most duodenal ulcer occur because there are no circular folds. The mucosa there is smooth. The second part is the part where bile and pancreatic juice enter the duodenum. The third part is where the superior mesenteric vessel cross the duodenum. Okay. So this point here, because I've written it here, let me talk about it. So if you are looking at features that are essential for absorption of food, because we said that the third part, the small intestine is the primary site of digestion and also absorption of nutrients. So what actually helps in this absorption? One, the circular foods. The circular foods increase the surface area. Then the presence of villi and microvilli, which further enhance the absorption. Now, where the duodenum ends, that is where the jejunum begins. Remember, the jejunum is intraperitoneal. So there's what we call at the duodenal junction, there is a musculoperitoneal fold that connects the right cruise of the diaphragm to the duodenal junction. So that one facilitates movements of intestinal content from the duodenum to the jejunum. Another point is that when you're dividing the GI tract into upper and lower GI tract, we use this junction. We use this junction. So this musculoperitoneal fold is called the suspensory ligament of the duodenum. So that parts up to this is the upper GI tract. Then from this going will be the lower GI tract. Now there's the jejunum and the ileum. The jejunum and the ileum. I explain. What I want you to note here is how do we distinguish the jejunum from the ileum? This one is the jejunum and this one is the ileum. The jejunum has a lot of circular folds. There are fewer circular folds in the ileum. As these circular folds occur, they will increase the surface area, and that's why we are saying that most of the absorption occurs in the jejunum. Then another thing is that we can use is about the vessel. If you look at here, the blood supply to the jejunum is called jejunal arteries, and the blood supply to the ileum is called iliac arteries. You can see that before it's these vessels, they lie within the mesentery. So we said that the mesentery carries blood vessels, lymphatics, and nerves. Now you can see that the iliac arteries, they form several loops, unlike the jejunal one. So we say that the ileum has several arterial arcades. The jejunum have fewer arterial arcades. Then finally, this straight artery, this one is called straight artery or the vasa recta. The vasa recta. They are longer in the jejunum, then they are shorter in the ileum. Because of the numerous circular folds that you find in the jejunum has a thicker wall than the ileum. There is another very important thing not shown here is the lymphatic nodules. In the jejunum, there will be solitary lymphatic nodules. In the ileum, these lymphatic nodules will aggregate, and we call it Peyer's patches. So if you look at here, the ileum, we are saying that it has a thinner wall, a smaller diameter, and more Peyer's patches. Not just more Peyer's patches, they have Peyer's patches. Peyer's patches are basically aggregation of what? Lymphatic what? Nodules. It looks like I didn't give any diagram to show that, but let me see. I think I can show you something so that you can appreciate the Peyer's patches that we are looking at. Then I'll also talk about the functions of these Peyer's patches. So ileum and jejunum. I decided to remove all the histology slides so don't worry. Now, so yeah. So this one is the ileum. Both ileum and jejunum, of course, will have villi. So these ones are representing villi. But I'm talking about these ones. We call this one lymphatic nodules. Now you see that in the jejunum, they've aggregated. So the aggregation of the lymphatic nodule is what we refer to as Peyer's patches. Remember, within this, there are a lot of what do you call it? White blood cells over there. So the Peyer's patches more or less will also form part or act as the first line of our defense. The first line of defense. So remember, anything that passes through the gastrointestinal tract, by the time they reach the ileum, we are saying that we have these immune cells within the lymphatic nodules that will offer immune protection. You find it in the ileum, but not in the jejunum and not in the duodenum. I've seen something here too that I think I can talk about. When I was looking at the duodenum, remember, I'm just trying to connect the histology small to help you better appreciate some of the things that we are talking about. Okay. Now, another thing that I want you to notice this. Okay, so I will not talk about it. I think I have a separate chapter for that. Then there's this condition, congenital condition, ilia diverticulum or Michel diverticulum. Now, this is the ileum. But you can have this extension here. This congenital out portion of the ileum is what we are calling Meckel's or ilia diverticulum. Is because during development, the vitamin duct fail to regress. So here, the vitamin duct, if it fail to regress, then can have this condition that we call Meckel's diverticulum. The problem with this one is that it can cause bleeding or there can be obstruction there. And that can mimic appendicitis. It can mimic appendicitis. It's the most common cause of severe painless rectal bleeding in children. It's present in 2% of the population. It occurs 2 feet from the ileocecal valve and usually 2 centimeters long, and may contain 2 types of ectopic tissues. You may have stomach, pancreatic, jejunal colic part within the iliac diverticulum. And symptoms usually occur before the child turns 2 years. So in gross anatomy, you only have to be able to differentiate between the jejunum and the ileum. And it's based on 1, the thickness. This is thicker. Luminal diameter. This is the jejunum is wider. The blood vessels, vasa recta, they are longer. There are case fewer. Amount of fat in the mesentery lesser compared to what you find in the what? In the ileum. And in terms of function, we are saying that most of obstruction occurs in the jejunum than the ileum. Then another point is the fact that the ileum is longer than the jejunum. Now, histology. The epithelium that lines the small intestine is simple columnar epithelium. When we say simple, it means that there's only 1 layer of cells. When you say columnar, it means that the shape of the cells are tall. They are shorter than they are wide. We have goblet cells and brush border. Brush border are basically microvilli. They are microvilli. Then goblet cells, they secrete mucus. So that's it. Now, how is the small intestine adapted for its function? I mentioned the plica circularis, the circular fossa, then the presence of villi, then the presence of microvilli. How do we distinguish the different segments of the small intestines? We realize that when after the stomach has digested the food into a semi-liquid chyme, remember there's acid in it. So we say acidic chyme that gets into the duodenum. Then we already explained that in the duodenum, that is where pancreas, the pancreatic juice, and bile ducts, they open into the duodenum. Therefore, for these pancreatic enzymes to work, this acidic chyme must be neutralized. So the duodenum in the submucosa have what we call submucosal gland, named after this person, Brunner's gland. So they secrete alkaline mucus to neutralize the acidic chyme from the stomach. Then I also said that the ileum have Hayes patches, which aggregated lymphotic what? Or lymphoid nodules. And that one play immune protection. So how do you identify the jejunum? No Brunner's gland. If it's not jejunum, And if there is not ileum, then of course it is jejunum. So no Brunner's glands or Peyer's patches. So please, Brunner's gland in the duodenum is very, very important, because before the pancreatic enzymes work, they need to, the acids will have to be neutralized. Then the Peyer's patches, the ileum is also very, very important. So in the absence of these two, then we are looking at the jejunum. Now, this one is just showing us the circular folds. This is the finger-like projection that we are calling the villi. And here you can see the villus, singular, villi, plural. Here you can see the goblet cells that will secrete mucus. And this is another microscope. These are the microvilli. Here they are trying to show, and the villi, they are trying to show what microvilli. So you see that the microvilli is also called a brush border. Now, if you look at the villi, you see capillaries, then you see lymphatic capillaries. This lymphatic capillary is called lacteal. And it is in this lacteal that the end product of lipid digestion will pass. And it will pass. So the end product of lipid digestion will be absorbed into the lacteal. The lacteal is a lymphatic capillary. And these things, these ones that I'm showing you, don't worry yourself so much. I just want you to note that within the small intestines, in the mucosa and epithelium, there are several cells. So I've already mentioned some of the cells. For example, they are the enterocytes. They are the enterocytes, or the absorptive cells. So these are the columnar cells that will have microvilli. They are absorptive, of course, so they help in the absorption of our nutrients. When there's damage to these absorptive cells, remember the absorptive cells will have what? Microvilli. So when there's a damage to these absorptive cells, or there's loss of microvilli, and there's lead to problem with absorption, a condition that we call celiac disease. Then we have the goblet cells that will secrete mucus to lubricate and protect the mucosa. Decrease in these goblet cells can lead to ulcerative colitis. Then there are some cells like the Paneth cells. Paneth cells are antibacterial. They help to maintain the intestinal flora. Depletion of these Paneth cells can lead to inflammatory bowel disease, and that one can increase bacterial invasion. Then we also have enteroendocrine cells that produce hormones like secretin, CCK. So some of the cells, the enteroendocrine cells secrete what? Hormones. Then there are the stem cells. These stem cells, they divide to replace the epithelial cells, and they do so every 3 to 6 days. The only one that takes longer time for it to be replaced is the Paneth cells. I think that one takes about a month. So when someone, what do you call it? What do you call it? So in chemotherapy, it affects these regenerative or these stem cells. They also have M cells. M cells, they overlay the Peyer's patches. And I told you the Peyer's patches contain immune cells. So what the M cells does is they are like antigen presenting cells. They sample the luminal antigen, then they deliver it to the lymphocytes that you find in the what? In the Peyer's patches. Find the Peyer's patches. So if organisms like Salmonella typhi, they actually target these what? M cells. And of course, once they target them, they they are not able to what? Destroy them. So okay, so remember the enterocytes, which are the absorptive cells, and how they are linked to celiac disease. Remember Paneth cells, how their depletion can lead to inflammatory bowel heart disease. Oh, so I'm looking at it once again. Okay. Okay, so this one, when you read it, you can understand it. So if you look at something like typhus, for instance, Salmonella typhi will invade the M cells. We are saying that the M cells cover the PS patches. So once they target the M cells, they cause inflammation. So that's the point that we're looking at here. They are targets for pathogens, these M cells. Okay. Then if you look at the celiac disease, it's an autoimmune from those people. You know, there are some people they don't like what they call it gluten. Autoimmune triggered by eating gluten. Gluten is a protein found in wheat, barley, and rye. So there is destruction of the villi. Then you have, when they say cleft hyperplasia, the clefts are actually glands. The clefts are actually glands. These cells here, you see that they call it intestinal clefts. So these cells, that's what they are talking about, that they tend to increase in what? In number. They tend to increase in number. So at the end of the day, once there is an atrophy of the loss of the villi, they will lead to more absorption. Now, this point and that point are basically what? The same thing. They're saying that damage in the enterocyte will lead to loss of microvilli. Now, this is the villus. So the villi, singular villus, will have microvilli. And the cells that you have here, one of the cells is what we are referring to as enterocytes. You see that they are labeling them. And these are the ones that will bear what? The microvilli. So there's autoimmune destruction of these enterocytes. So that will lead to loss of these microvilli. And that will lead to more absorption. Okay, so the large intestines. So this is the large intestines. This is the large intestines. So the large intestine is made up of the cecum, the appendix, then the colon, then the rectum, then the inner canal, then of course the anus. The colon, for descriptive purposes, we have the ascending colon, the transverse colon, the descending colon, then the sigmoid colon. The ascending and descending colon are fixed to the posterior abdominal wall. The transverse colon has a transverse mesocolon, so it's mobile. The sigmoid colon has a sigmoid mesocolon, it's mobile. The appendix has a mesoappendix, so that one too is what? It's mobile. We've already explained that the ascending and descending colon are secondary retroperitoneal organs. Now, when the ascending colon turns, where it turns is where we have the liver. So that turn is what we call the right colic flexure. And because the turn is where we have the liver, so we call it or can also call the hepatic pleasure. Then the transverse colon also tends here. So where we have the spleen. So we also the left colic pleasure is also called is also called the splenic pleasure. It's also called the splenic pleasure. Now, so I've already explained it. The large intestine is extend from the ileocecal junction to the anus. So this is the ileocecal junction or the ileocecal valve all the way to the anus. It's about 1.5 meters. The main function of the large intestine to absorb water and electrolytes, form and store feces. There are a lot of goblet cells. That's why you have a point there, mucus secretion. Then it houses some microorganisms, and these microorganisms synthesize vitamin K and also give us vitamin B complex like vitamins B6 and B12. Now, that is why once a while you have to be taking Greek yogurts. Not just Greek yogurts, just yogurts. Okay. The cecum, being the first part, is a blunt pouch below the ileocecal valve. So this is the ileocecal valve. So the part that is inferior to the ileocecal valve is the cecum. As the posterior aspect of the cecum, we find the appendix. We find the appendix. We find appendix. Okay. Now, you can use the extension of the cecum to, when there's obstruction, you can determine whether the obstruction is in the small intestines or the obstruction is in the large intestine by looking at the cecum. When the cecum is extended, then the obstruction is large bowel. And if the cecum is collapsed, that means that the obstruction is in the small bowel. There are three unique features that you find in the colon of the large intestines. Of course, because the colon is the largest part of the small intestines. When we're looking at special features of the large intestines, I think we'll be looking at those special features related to the colon. And one of them is the epiploic appendages. So these small fat-filled pouches along the colon is what we call the epiploic appendices. This one is unique to the large intestines, specifically the colon. Then there is what we call tinea coli. Tinea coli. So this is the tinea coli. Remember, I told you that the wall of the GI tract has inner circulator longitudinal muscles. Is this outer longitudinal muscles that has formed three longitudinal bands that we call tinea coli. So here we are only seeing one, but there are actually three. And all the three will converge behind the posterior to the cecum. And where they converge, that is where the appendix will emerge. So sometimes in trying to locate the appendix, you only have to trace the tinea coli. When you trace the tinea coli, the appendix can be located. Now, because the tinea coli or these longitudinal are shorter than the colon, when they contract, they give these outpouching. So these outpouching are formed by the tinea coli, three longitudinal bands of smooth muscles. These outpouching or circulation formed by the tinea coli is what we refer to as hostra or hostrum. So in the colon or the large intestines, you see these hostrum. You see these omental appendages. Then finally, you see these tinea coli. They are unique. Now, the position of the appendix is variable. The most people, the appendix is retrocecal. In 75% of the population, the appendix is behind the cecum, retrocecal. Now, in appendicitis, the maximum tenderness will be felt where the appendix is located. You know, the appendix is located in the right iliac fossa. So there is this point, the McBurney's point, which is 1/3 the line from the right anterior superior iliac spine to the umbilicus. If someone has appendicitis, maximum tenderness will be felt at this point. The McBurney's point is a line drawn from, is 1/3 the line from the right anterior superior iliac spine to the umbilicus. And that is where maximum tenderness will be felt if someone has appendicitis. Now, remember, the rectum is in the pelvic cavity. The rectum is in the pelvic cavity. Okay, I think I'll not even talk about the rectum. Don't worry. So, rectum, this is a rectum. If you look at the rectum does not have tinea coli. The rectum, no omental appendices. So those features that we mentioned, they are features common to the colon and the cecum. The appendix, the rectum, the inner canal, they don't have these features that we talk about. So remember that the rectum lacks the ostration, the rectum lacks the mental appendages, the rectum lacks the tinea coli. In fact, the word rectum means straight, but we know that the rectum is not straight. There are some curves. So the lower part of the rectum, this part being here, is what we refer to as the ampulla. The ampulla. Now, the rectum is in the pelvic cavity. So there's a muscle that forms the floor of the pelvic cavity, the pelvic diaphragm. One of the muscles is the levator ani. So when the rectum pierces the pelvic diaphragm, then we'll talk about the inner canal. So this side here is the inner canal. So the inner canal is located inferior to the pelvic diaphragm. So this muscle here, you're seeing the continuity here. The rectum pierces it. So inferior to this muscle, the levator ani, or the pelvic diaphragm, that part is what we're referring to as the inner canal. Now, if you look at the inner canal, there are these longitudinal folds that you see here. These longitudinal folds are called the inner columns. The inner columns. At the base of the fold, we have the inner valve, the space in between it being the inner sinuses. The inner sinuses. So you have these longitudinal folds as the inner columns. Then at the base, there's inner valve. Okay. One thing let me explain something here because I'll talk about hemorrhoid and why we talk about internal hemorrhoid and external hemorrhoid. There are 3 germ layers, ectoderm, mesoderm, and endoderm. At the junction here, let me use where you have this line here. Where they have done is not a nice place, but then let's take it like that. So then imagine this line here that they've drawn here is the pectinate line. In fact, the pectinate line should rather be here. But what is important is this. At this point, there is no mesoderm. So there is ectoderm and there is what? Endoderm. So there is this line here that we use embryologically to mark the junction between the endoderm and the ectoderm. So technically, if you are looking at the large intestines, the large intestine actually will end here. Will end here. Will end here. Because this part here is actually part of the large intestines. Then the part below is actually part of the perineum. What is significant is this. The blood supply, the innervation, lymphatic drainage of the part above the pectinate line is different from the part below the pectinate line. So that point is what I want to make. That the blood supply to the part above this line, the innervation above this line, lymphatic drainage above this line is different because above this line is endoderma in origin. Below that line is ectoderma in origin. Okay. Please watch the blood vessels here. See there's a venous blood here. See there's a venous blood here. When these venous blood here become dilated, you see what they are called? We call the hemorrhoidal veins. The hemorrhoidal veins. They are essentially rectal, inferior, they are essentially rectal veins. So when these veins become dilated, then this will be internal hemorrhoid. Then if the ones here rather becomes dilated, then it is what? External what? Hemorrhoid. I think I have, yes. So piles or hemorrhoid are swollen and inflamed veins in the lower rectum and inner canal. Internal hemorrhoid are above the dentate line, and they are usually painless. Why are they painless? They are painless because they are actually supplied by autonomic what? Nerves. Although they are painless, they may bleed. You see, the upper part, maybe by the autonomic nerves. The lower part, somatic nerves. When we're looking at the peritoneum, we said that the visual peritoneum is innervated by autonomic nerves, so pain is diffuse. Then the parietal peritoneum is innervated by somatic nerves. So you get it. Now, if the hemorrhoidal veins below the dentate lines become swollen and inflamed, then that is external what? Hemorrhoid. And external hemorrhoid are very painful because they are innervated by somatic nerves, specifically the inferior rectal vein. Of course, we know the cause of hemorrhoids: straining during what? Defecation, constipation, pregnancy, prolonged sitting can lead to this condition. The reason is that actually when you sit down to defecate, these veins becomes what? Dilated. So in a normal circumstance, you are not supposed to sit for long. You are not supposed to sit for long. The way the veins are actually positioned at some angles, 3 o'clock, and I think 9 o'clock or so. So that's how come you are seeing this dilation that you are seeing over there. Of course, the treatment involves lifestyle changes. If you take diet high in fiber and take a lot of fluid, it helps. And then, of course, you don't need to sit for long. Once you don't need to sit for long. Some people is when they go to their washroom that they try to reply. They spend a lot of time on their phones. Now, another point that they also need here is this: with respect to the inner canal, is that there's an internal inner sphincter. The internal inner sphincter is actually smooth muscles, and there is this one here, the external inner sphincter. the external inner sphincter. So the internal inner sphincter is a smooth muscle, and the external inner sphincter is a skeletal muscle. So a skeletal muscle means that it's voluntary. Now, so you realize that with you and I, because the external inner sphincter is a skeletal muscle and it's under conscious control, even if you want to go and identificate, you can actually tell that you can actually postpone it. I live within a certain limit. But with children, not so. This is because for them, the nerves, the corticospinal tract, the nerve that actually will innervate these external inner sphincters, they are not fully myelinated. So it is when they turn maybe past 3 years that they become myelinated, and that is when they begin to have conscious control of their external inner sphincter. So you should remember the sphincters that you have at the inner canal and what they do. Now, you can have these things also happening within the mucosa. You can have outpouching in the wall of the colon, and that's what we call the outpouching is what we call the diverticular. The condition is what we call diverticulosis, and these outpouching can become inflamed, condition that we call diverticulitis, and it usually cause pain, fever. Then you can have part of the intestine moving to another segment. Now, this view is not so nice, but then you can have, and that one, the important point is that it can lead to what? Obstruction. Yeah, it can lead to obstruction. So you can have something like here. This is the ileum. So the part of the ileum can protrude into the what? Into the colon. Into the colon. Now, in terms of histology, the epithelium that lines the small intestines is the same epithelium that lines the large intestines. The difference that you need to note is that in the large intestine, there are no villi. There are no villi. There are no villi. And we already know the function of the large intestines. How do we identify the colon? And how do you identify the cecum? We explained that in the colon, in the cecum and the colon, there is this structure here that we call tinea coli. The rectum does not have a tinea coli. So histologically, we can use the tinea coli to identify the cecum. We can use the tinea coli to identify the colon. We can use the absence of tinea coli to identify the what? The rectum. Identify the rectum. What are some of the cells that you can find here? Once again, you can have some enterocytes, and these enterocytes will absorb water and electrolytes. Lots of these ones can lead to diarrhea. We also talk about the goblet cells, the enteroendocrine cells, then the stem cells. It's the M cells that you can't find here. And the panel cells are not, are more, usually found more in the small intestines. Okay. I think I've mentioned this one somewhere. So under this inflammatory bowel disease, there's chronic inflammatory affecting the GI tract. There are two types, the Crohn's disease and the ulcerative colitis. In ulcerative colitis, affects only the colon and the rectum, and Crohn's disease can affect any part of the GI tract, usually the ileum. So this is chronic inflammatory disease. Now the complication, okay, you can read more about this one. Let me just Skip this one. There's sigmoid volvulus. Volvulus means twisting. You guys saw that the sigmoid colon has a sigmoid mesocolon. So you can have twisting of the sigmoid colon. And that one can lead to bowel obstruction. So that is sigmoid volvulus. Colostomy. Ostomy is where you create an opening. So in sweating where there's problem with the inner canal in the anus, an opening can be created on the colon where the feces will pass through the anterior abdominal wall. There is also no colonoscopy where the tube is passed through the anus to view the colon and the rectum. And usually recommended for people who are more than 50 years old. Okay. So the large intestines is you need to know the main parts of the large intestines, the main function of the large intestines, and then the sphincters are the inner canal, the external inner sphincter, the internal external and the internal inner sphincter. Those ones you should know. Those ones you should know. Okay. Then the epithelium that you find is large intestines. Yes, it's a simple columnar epithelium with microvilli and goblet cells. In fact, in the large intestine, the goblet cells are more. There are more goblet cells. Unlike the small intestines where you can have villi, the large intestines have like villi. Of course, in the large intestines, absorption of nutrients is not a goal, but what absorption of food, absorption of water. So that is for the large intestines. So let's look at accessory glands, digestive glands. I will start with the liver. We know where the liver is located anatomically in the right hypochondrial region, in the epigastric region, and it can even extend to the left hypochondrial region. In terms of digestion, the main point that I want to remember is bile production. So if the liver cells hepatocytes produce what? Bile. Produce bile. Now, so let's look at the liver proper. Now, this is the falciform ligament. This falciform ligament. The falciform ligament connects the liver to the anterior abdominal wall. And anatomically, we use the falciform ligament to divide the liver into right lobe and the left lobe. This part of the liver is the diaphragmatic part surface. And the part that you see here is the visceral surface. Now, so this is the falciform ligament. So here, this is the falciform ligament. So that the whole of this part here is the right lobe, and the whole of this part is the left lobe. Now you can see that the gallbladder lies at the visceral surface of the liver. So there's a gallbladder at the visceral surface of the liver. On the side of the gallbladder, there's a lobe of the liver that we call quadrate lobe. You can see it's four-sided. This lobe is called a quadrate lobe. The IVC will be positioned here. The inferior vena cava will be here. So the lobe of the liver here is called a caudate lobe. The caudate lobe. So there's a quadrate lobe of the liver, and there is the caudate lobe of the liver. So this is the quadrate lobe of the liver, and this is the caudate lobe. Once again, this is the falciform ligament. This is the falciform ligament. This one here is the falciform ligament. The gallbladder is at the visceral surface. This is the IVC. Between the fissure for the falciform ligament and the gallbladder, there is the quadrate lobe. And between the IVC, there is and the ligamentum venosus, there is the caudate lobe. So anatomically, the chordates, the quadrates are part of the right lobe of the liver. The area that we call the bare area of the liver, the area is bare in the sense that there is no peritoneal attachment. There is no peritoneal attachment. So the impression that you are seeing here are created by the viscera. So everything that you have is here. The right lobe is the largest lobe. The left lobe is smaller. It's separated from the right lobe by the falciform ligament. The caudal lobe is near the IVC. The caudal lobe is adjacent to the heart, to the gallbladder. Okay. Now, this area here is called the hilum of the liver, or the porta hepatis. This is where structures enter and leave the liver. So you see, one of them is the hepatic artery. Hepatic artery carries 25% of blood, oxygenated blood, to the liver. Then you have the hepatic portal vein carrying 75% of nutrient-rich deoxygenated blood to the liver. And finally, the common the hepatic duct. Hepatic duct, remember we said that the liver produces what? Bile. So bile duct will be leaving. So I think I have it here. The portal hepatis, hepatic artery entering, portal vein entering, then bile duct leaving. I think this one, so what I would say, common hepatic duct proper. That one will be better. Common hepatic duct. Now, clinically, they don't use the falciform ligament to divide the liver into right lobe and left lobe. They actually use an imaginary line passing the IVC and the gallbladder. They call it the cantilar line. And that one is very, very important. That one is very, very important because in this division is actually based on the blood supply and the binary drainage. In fact, the liver is divided into segments. So you can do lobectomy, you can do segmentomy of the liver. You can remove a particular segment of the liver without affecting other part. And you can also remove a particular lobe of the liver based on a segment without affecting. So the line passing here is the IVC, and the gallbladder is what is used to divide the liver into the right lobe and the left lobe. Now, histologically, the liver, this is a classic lobe of the liver. The liver is hexagonal. So these are hexagonal, so 6-sided hexagonal. So you have this hexagonal. Then at the center, there is a central vein, and that's what they are showing us. This is the central vein. Then you have liver cells, which we call hepatocytes, radiating from the central vein towards the periphery. So this is the central vein at the center. The center is the central vein. We are saying that it's 6-sided. At the corners, we have the portal triad. We know the portal triad, the portal vein, the hepatic artery, and the bile ducts. So you have liver cells, hepatocytes, radiating from the central vein into the bile ducts, into the portal area. Now, watch this point that I was saying. I explained to you that this is the hilum of the liver, the porta hepatis. So it is here that hepatic artery is entering. It is here the portal vein is entering. It is here the bar that is what is living. So what we are saying is that these hepatocytes that radiate towards the periphery. So and this is also another what hepatocyte. In between the hepatocytes, there is a special type of blood capillaries that we call sinusoid. So if I use this image, this is the liver cells hepatocytes. This is another liver cell hepatocytes. So in between, we have the type of blood capillaries that we call the sinusoid. So you can see here that hepatic portal vein is passing through the sinusoid. In the same way, hepatic artery is also passing through the what? The sinusoid towards the central what? Vein. Now, what is unique is this. The sinusoid, what are they? The blood vessels, the capillaries are lined by endothelial cells. So this is an endothelial cells. This is an endothelial cells. This is an endothelial cells. When it says sinusoidal capillaries, they are capillaries that have very, very, very big what? Spaces between them. Let me just put it that way. Just big spaces. This one, the way they've done it is quite small. Have big spaces. So hepatic artery will be passing here, carrying oxygenated blood. Hepatic portal vein will also be passing here, carrying what? Nutrient-rich deoxygenated blood. Then you realize that the liver also produces what? Plasma what? Proteins. So you see that material from here produced by the liver will just enter the capillaries. And the nutrients and everything that is also passing to the blood can also leave and enter the liver cells. So this is where exchange, this area here, between the liver cells and the endothelial cells, this is where the exchange of materials occur. And you realize that at that point, the liver cells there have these microvilli to increase the what? The surface what? To increase the surface area for this type of exchange. So this space here is called the space of DC. The space of DC, or the perisinusoidal space. Remember, I said that this is the sinusoid. So perisinusoidal space. It facilitates exchange of nutrients, plasma proteins, and lipid between the liver cells and the sinusoid. Within this space, there's what we call the ito cells. The ito cells, they store vitamin A, and we know vitamin A importance in the eye in terms of night vision. Then finally, you also will see this special type of cell. We call it the kappa cells. The kappa cells. So the kappa cells are macrophages. The kappa cells are macrophages. So they are phagocytic. They remove debris and pathogens from the blood. So it means that if all these kappa cells, they are resident macrophages. They are resident macrophages in the liver. They are resident macrophages in the liver. So their job is to remove any debris or any pathogens that would have entered. Another important point is the fact that the liver cells hepatocytes have a lifespan of about 5 months. We know that the liver cells can regenerate, so it's coming from this point. Now, although I've given the notes to you, whatever I talk about, that is what you need to know. Yes. So I think I'm not going to explain these ones. I think just get this point that I've mentioned. Just this diagram here. This one explains how blood flow through the liver. Explain how blood flow through the liver. So the hepatic artery portal vein. So then we are saying that they flow through the what? The sinusoid. And as they flow through the sinusoid, there's essential material between the sinusoid and the liver cells. And that agent of material occurs here, the space that we are calling the space of what? DC. At that space, there is a type of cell that we call the aether cells that stores vitamin A. Not only that, when the liver there's an injury to the liver. There's an injury to the liver. These aether cells, they behave differently. They behave differently. They become like myofibroblasts, where they begin to secrete what collagen fibers. So that's why you have here that is participating in fibrosis. So in the early sign of, one of the problem in the liver is liver cirrhosis. So in the early sign of liver damage, these aether cells will begin to produce what collagen fibers, and that will mark the beginning of what liver cirrhosis. So I'm not going to explain the other points. Okay, I can talk about one because I explained that the liver also produces bile. The liver also produces bile. The liver also produces bile. So you let me leave that one. Then the gallbladder. We have already explained that the gallbladder is located at the visceral surface of the liver. And there's a fundus, there's a body and a neck. So this is a gallbladder. There's a fundus of the gallbladder. There's a body of the gallbladder. There's a neck of the gallbladder. And the gallbladder has a cystic duct. It has a cystic duct. The function of the gallbladder is to store and concentrate bile. Then it also releases bile under the stimulation of this hormone. Bile will emulsify fat. That means break fat into smaller droplets, increasing the surface area for enzyme action. For enzyme action. Now, we explained that the liver produces bile. Let me see whether I can get an image. So this is a liver cell, and this is another liver cell. So you can see something here. This tiny canal that you're seeing here, we call it bile canaliculi. So when bile is produced by the liver cells, it first will drain into this bile canaliculi. Eventually, you have them living through here. There's a left hepatic duct and there's a right hepatic duct. The right and left hepatic duct will form the common bile duct. Then the bile will flow through the cystic duct, then get stored in the gallbladder. When the bile is needed, or called the hormones, CCK will be released. Then the bile will then flow through the cystic duct. Then it joins the common hepatic duct to form what we call the common bile duct. And you can see here passing behind the first part of the duodenum and behind the head of the pancreas. Then it will meet the pancreatic duct. I think let me end that part. Now, sometimes you can have gallstone forming. The gallstone is the stone is what we call the cholelithes. Then cholelithiasis is the condition. And the stone can be from cholesterol, calcium salt, or from what bilirubin, which is actually a component of the bile. So you can have cholesterol stone, which is the most common pigment stone. Here I'm talking about the bilirubin base. Then you can have a mixture of both cholesterol and bilirubin. Now, if a gallstone forms and the stone is here in the fundus of the gallbladder, if the gallstone forms, the gallstone can block the cystic duct. This is here. And that can lead to inflammation of the bowel of the gallbladder. Okay. Now, so you're talking about stone being stuck here in the cystic duct. So it means that bile cannot flow. So you can have the gall being inflamed. Or if it blocks here, the common bile duct, then it can lead to what? Jaundice. Can lead to jaundice. It can also get stuck here, the junction between the bile duct and the pancreatic duct, the hepatopancreatic ampulla. And when that happens, the bile can push into the pancreatic duct and lead to what? Inflammation of the pancreas. Now, bile stones within the fundus can erode into the duodenum, or it can erode into the duodenum. This is the duodenum, or can erode into the what? The colon. And that one can lead to some what? So here you have an abnormal what connection forming. And if it's that massive, then of course it can lead to what they call it, obstruction. Okay. So we are looking at gallstone and where if it lodges, the complication that can result from that. Then finally, in terms of the histology, we explained that the gallbladder stores concentrate bile. And because a concentrate bile, of course, the epithelium is going to be simple columnar with numerous microvilli. So the microvilli will increase the surface area so that there will be water and electrical absorption to be able to concentrate the bile. Now, within the wall too, there will be muscles, and it is the contraction of the muscle that will help to push the bile into the bile the cystic ducts. So this is the composition of bile. You can read about it. Now the pancreas. In anatomy, the pancreas, we say that it's vitreoperitoneal. In fact, except small tail, there's small tail, the concavity, the pancreas extends from the C-shaped duodenum to the tail, to the hilum of the spleen. And one important relation of the pancreas, anterior relation of the pancreas, is the stomach. Now, this is the head of the pancreas. This is the neck of the pancreas. In fact, the head has this oscillate process. Then this is the neck, then this is the body, and this is the tail of the pancreas. So you realize that anything that affects the head of the pancreas, like cancer of the head of the pancreas, can affect the duodenum. It can also affect the stomach. Can also affect the stomach. it will definitely also affect bile flow and what do you call it? Not bile, but also pancreatic juice, because you realize that the bile duct and the pancreatic duct, they actually join here. Okay. Now, the pancreas is both an exo and endocrine gland. We are interested in the exocrine function, and that is the part that produce what digestive what enzymes. Produce digestive what enzymes. Now, I want a pancreas. Oh, okay. So this one is not a very nice diagram that I have here for the pancreas. I thought I have a bigger diagram. Okay, let me use it like that. Let me use it like that. So if you look at here, this is a pancreatic duct. This is a bad duct. In some people, they may have this thing here. We call the accessory pancreatic duct. That would drain thick bile from the head. The main pancreatic duct spans along the entire length of the pancreas. Span the entire length of the pancreas. Okay, so whatever I'm going to talk about is here. So I've already explained how the bile that is produced by the liver eventually gets into the gallbladder. Then how when bile is needed, how the bile is going to flow. Okay. Now watch here. We are saying that the bile duct and the pancreatic duct, they join here. This union here is what we are calling the hepatopancreatic ampulla. Named after this person, Vata. So the ampulla of Vata. Now this one open at the major duodenal papilla. There is a smooth muscle at the hepatopancreatic ampulla. We call it the sphincter of the hepatopancreatic ampulla, or the sphincter of ampulla, or the sphincter of Oddi. So what it means is that this smooth muscles is then going to control the release of bile and pancreatic juice into the duodenum. So everything that I've said is here. So everything that I've said is here. Okay, so that is that. Now, blood supply to the GI tract. Once you understand image, that is all. Everything that is colored yellow here, including the spleen, from the stomach, the liver, the gallbladder, the esophagus, the stomach, the pancreas, the spleen, then the first part of the duodenum up to the major duodenal papillae. All these structures are derived from the foreguts. So the celiac trunk, the blood supply is coming from the celiac trunk. So this is the celiac trunk. It gives branches that will supply the derivative of foreguts. So here you can see the celiac trunk giving rise to the left gastric artery. There's a right gastric artery. So when you hear the name gastric artery, there's a part that is going to the spleen, the splenic artery. That splenic artery gives branches that will supply the stomach. That also supply the pancreas. Then there's a hepatic artery, which is going to the liver. That hepatic artery also gives branches that will go and supply the gallbladder. So that's the cystic artery. Then there's a part of the hepatic artery, common hepatic artery, that will branch to supply the first part of what? The duodenum, and the stomach again. So just know that blood supply to the liver, to the derivative of the foregut is from the celiac trunk. So everything yellow. Then blood supply to the midguts. When I say midguts, in the during development, there are three gut tubes: foregut, midgut, hindgut. The foregut would develop to form structure that you see in yellow. The midgut would develop to form structure that you see green, and the hindgut would develop to form the structure that you see at brown. So from the major duodenal papillae all the way to the transverse column, I mean the jejunum, the ileum, the cecum, the appendix, the ascending column, the tutor transverse column, and the part of the duodenum, they are all derived from blood vessel we call the superior mesenteric artery. So if you look at this one here, as the superior mesenteric artery, you see giving branches to supply this part of the duodenum is the one that's giving rise to the jejunal arteries, giving rise to the iliac arteries, giving rise to the ascending colon, giving rise to the transverse colon, giving branches to supply the cecum, and giving branches to supply the appendix. Then the inferior mesenteric artery will supply the distal part of the transverse colon, the descending colon, the sigmoid colon, and the rectum. So you can see here the inferior mesenteric artery supplying the descending colon, supplying the sigmoid colon, supplying the what? The rectum. So this is briefly the blood supply. Now, for lymphatic drainage, everything goes to the liver. So there's something I will call hepatic portal vein. This is the hepatic portal vein. This hepatic portal vein is formed behind the neck of the pancreas. It's formed by the union of the inferior mesenteric vein. It's formed by the union of the splenic vein and the superior mesenteric vein. So this is the superior mesenteric vein and this is the splenic vein. They join to form the portal vein. The inferior mesenteric vein drains into the splenic vein. So simply put, the hepatic portal vein carries nutrient-rich deoxygenated blood from the GI tract, the pancreas, the spleen, the gallbladder to the liver for metabolism and detoxification before it goes to the IVC. Then the IVC takes it to the heart. Now, this hepatic portal vein is valveless. It's valveless. It's valveless. So, depending on the pressure, that will determine how blood will flow. So, when there's a problem with the liver, there's liver cirrhosis, you realize that there was going to lead to a condition that we call portal hypertension. So, you realize that because the pressure here is high, the blood will flow back. These portal systems have a connection to the systemic system. So with that connection, blood will still return to the heart through this pathway. We call that the portal systemic anastomosis. The portal systemic anastomosis. Finally, in terms of the innervation, I've already explained the intrinsic innervation. I've talked about the submucosal plexus for gut secretion. I've talked about the myenteric plexus for gut motility. In terms of the autonomic innervation, this diagram is enough. This diagram is enough. The sympathetic innervation, because they are smooth muscles in the wall of the GI tract, they will be innervated by the autonomic nerves. because they are glands that will secrete something, they are also innervated by the autonomic nerves. These submucosal plexus and the mesenteric plexus, I'm saying that they can work independently of the central nervous system. But then there's also an extrinsic component, the sympathetic and the parasympathetic. The sympathetic is activated and what we call the fight and flight response. So when a sympathetic nerves are activated, it inhibits GI tract. In other words, if you need to run away from danger, that's not the time that the gallbladder will release bile. The gallbladder is not going to contract to release bile. No. But what as you are seated and listening to me, is the parasympathetic nervous system that is at work, and which is the rest and digest. So in this image here, we are looking at the nerves that give parasympathetic innervation. So the one that you see blue is the parasympathetic nerve. So look at here. Parasympathetic innervation to the foreguts and the midgut is coming from the vagus nerve. So parasympathetic innervation to the foregut into the midgut. The foregut is everything that are colored yellow and everything that are colored what do you call it? Green. All those structures. The parasympathetic innervation is from the vagus nerve. Then from the hindgut, the parasympathetic innervation is from the pelvic splanchnic nerve, which comes from the S2 to S4 segment of the spinal cord. Vagus nerve is the 10th cranial nerve. So parasympathetic innervation will increase peristalsis, will increase secretion, will relax the sphincters, will contract gallbladder so that the gallbladder can release bile. Sympathetic innervation to the GI tract is coming from T5 to L2 segment of the spinal cord. T5 to L2 segment of the spinal cord. The lumbar segment of the spinal cord will supply the hindguts, whereas T5 to T11 or segment of the spinal cord will supply the foreguts and the midgut. Sympathetic innervation will inhibit peristalsis, will reduce secretions, will contract the sphincters, and will relax the gallbladder. When you have pain from the viscera, when you have pain from the viscera, they will be referred to an area on the skin. Pain from the foregut will be referred to the epigastric region. Pain from the midgut will refer to the umbilical region. Pain from the hindgut will be referred to the suprapubic region. Let me use one to give an example. For example, if someone has appendicitis, now if the visceral peritoneum is involved, the person will not be able to localize the pain. That pain will be referred to the umbilical, so the person will feel that the pain is coming from here. But then when a parietal peritoneum is involved, it is then that the person will be able to localize the pain, be able to tell that, okay, the pain is coming from this point at the right iliac fossa. I don't have time to explain referred pain, but then this is an image showing pain from the stomach, the duodenum, the jejunum, and the area of the skin where the pain will be referred. Pain will be referred. Okay. Any question? So if you look at the appendix, any question? If you look at the appendix, you see the spinal cord level is from sympathetic. Pain will follow the sympathetic pathway, but not the parasympathetic. So pain from, and we are saying that from T5 to L2 segment of the spinal cord, they give sympathetic innervation to the GI tract. And when there is pain from the viscera, they will follow the sympathetic pathway. Now, if you look at, for example, the appendix, you see that it be coming from the sympathetic nerve will be coming from T10 to T11 segment of the spinal cord. And if you look at this area here, we call this one dermatome. Dermatome is an area of the skin supplied by a single spinal nerve. So if you look at here, around umbilicus is T10, and this one here is T11. So when there is a visceral pain, the visceral pain will be referred to an area on the skin corresponding to the what? The dermatome supplied by the spinal cord segment. So because this one is T10 to T11, they refer to that area of the skin corresponding to what? The dermatome. Okay. Any question? So this is a summary of innervation. Parasympathetic innervation, foreguard vagus, midguard vagus. Parasympathetic innervation, hindguard, pelvic splanchnic nerve. Effects. Sympathetic innervation, foreguard. I said that I just put all of them together from T5 to L2 segment of the spinal cord. Pain from the foreguard will be referred to the epigastric region. Pain from the midguard will be referred to the umbilical region. Pain from the hindguard will be referred to the suprapubic or the hypogastric region. So this simplifies the innervation of the GI tract. Any question? Any question? Hey, I muted all of you, so I will not be surprised that you can't ask any question. Any question? Okay, so what I'll do is this. I realize that there is I decided I wanted to give you questions, but then that will be from the Zoom, but then I realized that they don't want exams to be done that way. So I'm not going to do it that way. I think you have a platform. So I'll use that platform when I give questions to you. So I'll try and give you questions to you on the GI tract. And those ones are just straw questions. So if you're able to answer those ones, those are the basic things that I want you to know. That is all. It's more or less a summary of the points that I want you to know. And those are the ones that I will examine you on. Salif, you can ask your question.
Good evening, sir.
Yes.
Please, can you kindly go back to the summary table?
The summary table.
Yeah.
For the this one.
The innovation, yes, please. Yes. Please, can you explain it again?
What I'm saying is that when it cuts, then it means that our time is up. What I'm saying is that the GI tract, there are smooth muscles there. There are glands there. Those glands and smooth muscles, they are innervated by autonomic nerves. If they were to be skeletal muscles, then they will be innervated by somatic nerves. So elevation of the GI tract is by the autonomic nerves. Now, the autonomic nerves, we have the parasympathetic and the sympathetic. And the sympathetic nerves, they are activated when you are like under fight and flight in an emergency situation, when you are angry, those kind of things, when you are stressed. So that's what is activated. So I'm saying that in sympathetic innervation, there will be going to be decreased secretions because that's not the time that the stomach will release the gadolinium juice. You have to run away from danger. You are not going to release the pancreatic juice. No, 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 no. There will be blood will move to the limbs so that you can run away from danger. Blood, your pupils are going to dilate so that you can see your way that you can run. That's not the time for peristalsis is going to slow down. So we are saying that the nerves, sympathetic innervation, will come from T5 to L2 segment of the spinal cord. T5 to L2 segment of the spinal cord. So that's it.
Thank you, sir.
So those from the lumbar segment of the spinal cord will innervate the hindgut, and those from T5 to T11 segment of the spinal cord will supply the foregut and the midgut. That is the sympathetic innervation. Then I'm saying that when you have pain, the pain is not going to travel along the parasympathetic pathway. The pain is going to travel along the sympathetic pathway. So pain from the foregut will be referred to the epigastric region. Pain from the midgut will be referred to the umbilical region. And pain from the hindgut will be referred to the hypogastric region. But remember, the nerves are coming from T5 to L2 segment of the spinal cord. So I made that there's this table here that is telling us that if it's sympathetic innervation to the appendix, it's coming from T10 to T11 segment of the spinal cord. So we are saying that if you have pain from the appendix, that pain is referred to an area on the skin that corresponds to a particular dermatome. And what is a dermatome? A dermatome is an area of the skin supplied by a single spinal nerve. So let me give you an example here. You see, when there's a medical examination and you scroll the abdomen, what are you doing? You are checking the nerves. Which nerves? You are checking T6, T7 to L1 segment of the spinal cord. So we are saying that if the problem is the appendix, and the appendix is the visceral peritoneum is affected, the pain will be referred to the umbilicus, because the dermatome around the umbilicus is T10. But when the parietal peritoneum is involved, that is when you'll be able to say that the pain is coming from here. Why? Because parietal peritoneum are not supplied by autonomic nerves. They are supplied by somatic nerves. So in that case, you'll be able to pinpoint that the nerve, the pain is coming from where? Coming from the right iliac fossa. I said the visceral peritoneum are innervated by autonomic nerves. Parietal peritoneum are innervated by somatic nerves. Then I'm also saying that, what about parasympathetic innervation? Like you are seated now, listening to me, probably you have eaten. For your foregut and your midgut, the nerves that give parasympathetic innervation, that increases secretion, that increases peristalsis, that tells the gallbladder to contract. That one is the vagus nerve. That is the vagus nerve. For the foregut, for the midgut, but for the hindgut is the pelvic splanchnic nerve. For the hindgut is the pelvic. This one is what we call the pelvic splanchnic nerve. Is the pelvic splanchnic nerve. But then I also said that within the wall of the GI tract itself, There's a submucosal plexus, there's a mild enteric plexus, and these ones are able to work independent of the central nervous system. There is this condition, you can go and read about it, where these cells fail to migrate to the wall of the GI tract. Okay. So thank you very much. We are done. I'll get the course, the IT people, and I'll put those questions. When I put those questions there, you try and answer those questions. They are going to be very, very simple. Next week, we'll look at the UNI system. Next week, the UNI system, I'll finish it because your other lecturer has taught you. I think I'll even give you the notes. I've gone through his notes. There are one or two things that I want to stress on. Now, one or two things that I'll stress on, and that will be all. Thank you very much, and have a wonderful afternoon. Bye-bye.
Thank you, sir. Have a blessed Sunday.
Thank you, sir.
Thank you, sir.